My name is Joanne Orrick. I'm a clinical pharmacist with the North Florida AIDS Education and Training Center. During this presentation, I will provide a brief overview of HIV and AIDS to serve as a foundation as you review additional resources for the first IPLH session. Following this presentation, you should be able to identify important points in the HIV/AIDS timeline in the United States, describe the Ryan White HIV/AIDS program, the National HIV/AIDS Strategy, and the HIV Care Continuum, describe the epidemiology of HIV in the U.S. and Florida, describe recommendations for HIV testing, and explain the pathogenesis and natural progression of HIV infection. In June of 1981, the U.S. Centers for Disease Control and Prevention published a report describing cases of a rare lung infection, pneumocystis carinii pneumonia, or PCP, in 5 young previously healthy gay men in Los Angeles. All of these men also had other unusual infections that indicated that their immune systems were not working properly. This marks the first official reporting of what would become known as the AIDS epidemic. On the next few slides, we will review some important time points in the HIV/AIDS epidemic in the U.S. These are only some selected key time points, and a more thorough timeline can be reviewed at the website listed here. In 1981, there were again 5 reported cases of PCP in gay men. There were also 26 reported cases of Kaposi sarcoma in gay men. This is a very rare aggressive cancer. AIDS at that time was known as the gay plague or GRID, gay-related immunodeficiency syndrome. In 1982, the CDC linked HIV to the blood supply when some patients, including some infants, became infected with the virus after receiving blood transfusions. The term AIDS or acquired immunodeficiency syndrome was used for the first time in 1982. The first HIV antibody test was approved in 1985, and in that same year, the blood supply began to be tested for the virus. In 1986, scientists agreed on the name human immunodeficiency virus, or HIV, for the virus that causes AIDS. The first antiretroviral agent was approved in 1987. This is zidovudine, or AZT. In 1990, Ryan White died, and the Ryan White Care Act was passed. We will discuss Ryan White in a few moments. In 1995, the FDA approved the first protease inhibitor, or PI. At this time, highly active antiretroviral therapy, or HAART, using 2 nucleoside reverse transcriptase inhibitors, or NRTIs, plus a PI, became the standard of care. In 1998, the CDC released the first national HIV treatment guidelines. Among other recommendations, these guidelines provided recommendations of when to start antiretroviral therapy. At this time, the guidelines recommended to start ART early, that is, in patients with a CD4 count of less than 500 or a viral load of greater than 20,000. In this same year, the first non-nucleoside reverse transcriptase inhibitor, or NNRTI, efavirenz, was approved, and this allowed for a non-protease inhibitor-based HAART option. In 2000, resistance testing was recommended to guide therapy after treatment failure. This was a key time point in the treatment of HIV because it allowed us to determine which specific medications in a regimen were no longer working so that we did not have to change all of the medications when a regimen failed. In 2001, the treatment guidelines revised the recommendations of when to start antiretroviral therapy, and the recommendation was to start ART later. That is, in patients with a CD4 count of less than 350, so patients with even weaker immune systems, or a viral load of greater than 55,000. This is because the risks of early therapy in terms of side effects and long-term toxicities outweighed the benefits, or the known benefits, of early therapy at that time. In 2004, the guidelines recommended to start ART even later, and that is in patients with a CD4 count of less than 350 or a viral load greater than 100,000. In 2006, the first single-tablet regimen was approved, and we now have several different single-tablet regimens available. That is, regimens where we have all of the medications available in a single pill that the patient can take once a day. At this time, baseline resistance testing was recommended so we could see if patients were infected with a resistant virus, and this would help guide us in our initial regimen selection. In 2012, the guidelines changed to recommend ART for all patients regardless of the CD4 cell count or viral load. That is because a few studies showed that there was a clear benefit to starting antiretroviral therapy earlier, and we now have a lot of different medications available that have a lot less side effects and long-term toxicities. With the availability of over 25 different antiretrovirals and the use of highly potent combination antiretroviral therapy as a standard of care for all HIV-infected patients, HIV has now become a treatable chronic illness. I think the information on this slide proves that point. This slide shows the cumulative proportion of AIDS patients surviving by months after the first AIDS-defining opportunistic illness, or OI, from 1984 until 2000. As an example, take a look at the 24-month time point. In the 1984 to 1985 time period, less than 25% of patients were alive 24 months after the diagnosis of an OI. Whereas in 1999, about 80% of patients were alive at 24 months. So who was Ryan White? Ryan White was a boy diagnosed with HIV in 1984 at the age of 13. He had hemophilia and acquired HIV through a blood transfusion. He experienced a lot of stigma and discrimination, including not being able to attend school because of the fact that he was infected with HIV. Ryan and his mother became advocates for the rights for people living with HIV and AIDS. The Ryan White HIV/AIDS program is funded through the Ryan White Comprehensive AIDS Resources Emergency Act, or CARE Act, which was passed in 1990, the same year that Ryan White died. The funding level for this program was $2.3 billion in fiscal year 2016. And the program assists approximately 52% of people living with HIV in the U.S. The program provides a comprehensive system of care for uninsured and underinsured people with HIV. It supports primary medical care and the AIDS Drug Assistance Program, or ADAP, as well as key support services such as medical case management and temporary housing assistance. It also supports the AIDS Education and Training Centers, which provide technical assistance and education to increase the HIV workforce. This program is important in supporting the care and treatment for those living with HIV in the U.S., which is essential to prevent further spread of HIV. The National HIV/AIDS Strategy is a 5-year plan that details principles, priorities, and actions to guide the national response to the HIV epidemic. The strategy was first released in 2010 and identified a set of priorities and strategic action steps tied to measurable outcomes for moving the U.S. forward in addressing the domestic HIV epidemic. The strategy was updated in July of 2015, providing goals through 2020. The goals of the strategy are to reduce new infections, increase the access to care and improve health outcomes, reduce HIV-related health disparities, and achieve a more coordinated national response to the HIV epidemic. There are many indicators detailed in the National HIV/AIDS Strategy, and this is just a selection of those indicators towards meeting the goals of the strategy. One is to increase the percentage of people aware of their HIV status by 90%, decrease the number of new infections by at least 25%, increase the number of newly diagnosed people who are linked to HIV medical care within 30 days to greater than or equal to 85%, It's important to point out that the indicator related to linkage to care in the prior strategy that was released in 2010 allowed for the patient to be linked to medical care within 90 days of diagnosis. And finally, to increase the number retained in HIV care to greater than or equal to 90%. Again, this is just a selection of the many indicators that are outlined in the strategy. So let's take a look at the HIV epidemic in the U.S. by looking at the rates of adults and adolescents living with diagnosed HIV infection. This shows the rates per 100,000 population in the United States and 6 dependent areas at the end of the year 2013. The areas with the maroon color are the areas with the highest rates of adults and adolescents living with HIV, and as you can see, Florida has one of the highest rates. This slide shows the percentages of stage 3 or AIDS classifications among adults and adolescents with HIV infection by transmission category and year of diagnosis from 1985 to 2014. The percentage distribution of HIV infections classified as stage 3 AIDS by transmission category has shifted since 1985. In 1985, male-to-male sexual contact accounted for an estimated 65% of all cases. This percentage reached its lowest point in 1999 at 40%. Since then, the percentage among persons with HIV infection attributed to male-to-male sexual contact has increased, and in 2014, this transmission category accounted for 54% of all infections classified as stage 3 AIDS. The percentage of diagnoses attributed to injection drug use increased from 20% to 31% during the 1985 to 1993 time period and has decreased since that time, accounting for 11% in 2014. The percentage of diagnoses attributed to heterosexual contact increased from about 3% in 1985 to 31% in 2014. This slide shows the percentages of stage 3 AIDS classifications among adults and adolescents with diagnosed HIV infection by race and ethnicity and year of diagnosis from 1985 to 2014. The percentage distribution of HIV infections classified as AIDS among racial and ethnic groups has changed since 1985. The percentage of infections among whites has decreased, while the percentage among Blacks and African Americans and Hispanics and Latinos have increased. This slide shows the estimated lifetime risk of acquiring HIV in the U.S. based on a CDC analysis that was presented at the Conference on Retroviruses and Opportunistic Infections in 2016. The estimated lifetime risk of acquiring HIV in the U.S. is 1 in 99. However, there are marked discrepancies by race, risk group, and geography. Here you will see the lifetime risk by state. The states that are the dark purple are states that have the highest lifetime risk of persons acquiring HIV. In Florida, the estimated lifetime risk is 1 in 54. On the top graph, you will see the lifetime risk of HIV diagnosis by transmission group. Men who have sex with men, or MSMs, have the highest risk of acquiring HIV in their lifetime, with a 1 in 6 estimated lifetime risk. Next, you will see the lifetime risk by race ethnicity. African American men have the highest estimated lifetime risk of 1 in 20. And finally, you'll see the lifetime risk among MSM by race and ethnicity. African American MSMs have a 1 in 2 estimated lifetime risk of acquiring HIV. On this slide, you will see an overview of the HIV epidemic in Florida. It was estimated that in 2014, there were 4,613 newly diagnosed cases of HIV infection. There were also approximately 2,300 newly diagnosed AIDS cases. It's estimated that through 2014, there were 110,000 people living with HIV disease in Florida. And it's estimated that in 2014, 878 people died from HIV-related deaths in Florida. The HIV care continuum is a model that outlines the sequential steps or stages of HIV medical care that people living with HIV go through from their initial diagnosis to achieving the goal of a suppressed HIV viral load. And it shows the proportion of individuals living with HIV who are engaged at each stage of the continuum. It is important to point out that even though this continuum is often outlined as a linear process, patients often go back and forth between certain categories, such as being on and off antiretroviral therapy or being engaged in care or out of care. Here you will see a summary of the HIV care continuum in the U.S. in 2011. It was estimated that 1.2 million people were living with HIV as of 2011. Of those, 86% were diagnosed, 40% were engaged in care, 37% were prescribed antiretroviral therapy, and 30% had a suppressed viral load. Of the 70% of patients who did not have a suppressed viral load, the vast majority of these people were not in care. They were diagnosed with HIV, but they were not in care. Here you will see a summary of the HIV care continuum in Florida in 2014. In 2014, it was estimated that approximately 110,000 people were diagnosed with HIV. Of those, 90% were ever in care, and about 64% were retained in care. 67% were on antiretroviral therapy, and 58% had a suppressed HIV viral load to less than 200 copies per ml. It is important to point out that these percentages are of the people that have been diagnosed with HIV infection. 83% of those diagnosed with HIV in 2014 had documented HIV-related care within 3 months of diagnosis. Again, this was the engagement and care indicator in the prior National HIV/AIDS strategy. Now the engagement and care indicator is within 1 month of diagnosis. 82% of people living with HIV in care had a suppressed viral load in 2014. The first step in engaging people with HIV in care and getting them on antiretroviral therapy is diagnosing their HIV infection. Routine screening for HIV infection is recommended in all healthcare settings. It has been recommended by the CDC since 2006, and it is recommended for all patients between the ages of 13 and 64 unless there's a prevalence of undiagnosed HIV infection of less than 0.1%. This would not be the case in any place in Florida. Opt-out screening is recommended, and as of 2015, Florida now allows for opt-out testing. This means that patients should be told that they will be tested for HIV infection unless they opt out of the screening. In the past, it was required to get informed consent for performing the HIV test. Repeat screening for HIV infection should occur for people that are high risk for acquiring HIV infection, including injection drug users and their partners, and MSMs or heterosexual persons who themselves or their partners has had a greater than one sex partner since their most recent HIV test. There have been improvements in the ability to diagnose HIV infection over the years. When the first generation antibody test was used, it could take more than 50 days since the time of infection to be able to detect the HIV antibody. There is now a fourth-generation antibody-antigen combination test which allows for much earlier diagnosis of HIV infection. While this antigen-antibody combination test decreases the window of time between exposure to HIV and the ability to diagnose with testing, it is important to remember that in some cases you may still miss acute HIV infections, and if acute HIV is suspected, an HIV viral load should be done in addition to the HIV antigen-antibody combination test. This slide shows the new CDC recommendations for HIV testing in laboratories using the fourth-generation HIV test. The test is first performed to detect the HIV P24 antigen. If this is positive, then the HIV-1, HIV-2 differentiation assay is done. If that is positive, then the person is diagnosed as having HIV infection. If that is negative or indeterminate, a nucleic acid amplification test is done. If this test is positive, then the person is diagnosed with acute HIV infection. However, if this is negative, then the test is having a false positive and the person is diagnosed as HIV negative. Patients that are infected with the HIV virus can experience symptoms of acute HIV infection, and these symptoms occur before the body has had time to develop the antibody to the virus. These symptoms can include fever, weight loss, malaise, sore throat, lymphadenopathy, rash, GI symptoms such as nausea and vomiting, and myalgias, as well as enlargement of the liver and the spleen. How is HIV spread? HIV can be transmitted through sexual contact, injection drug use, from mother to baby during pregnancy, childbirth, or breastfeeding, through occupational exposures such as needle stick injuries, and through blood transfusions or organ transplants. Anal sex is the highest risk sexual behavior, and vaginal sex is the second highest risk sexual behavior. HIV is not spread by air or water, insects including mosquitoes or ticks, saliva, tears, or sweat, casual contact like shaking hands, hugging, or sharing dishes or drinking glasses, through drinking fountains, or toilet seats. Here you will see an overview of the HIV life cycle. In order to reproduce, the HIV virus needs to take over the person's CD4 cell. The HIV virus is a retrovirus, meaning that it has RNA as its genetic material. The first step in taking over the CD4 cell and producing more virus is binding with the CD4 cell, and also called attachment. The next step is fusion, followed by reverse transcription using the reverse transcriptase virus, which the virus has itself. Reverse transcription allows for viral DNA to be created. The viral DNA is then integrated into the host cell DNA. Next, replication occurs, followed by assembly and budding and full maturation of additional virus particles. We have antiretroviral agents that attack various steps in this HIV life cycle process. This slide depicts the natural progression of HIV in patients that are not on antiretroviral therapy. In the blue, you will see the CD4 cell count, and the red, you will see the HIV RNA copies per milliliter of plasma. When primary infection occurs, there is a lot of viral replication that is going on during the first few weeks of infection. During this time, acute HIV symptoms may occur, and there is a rapid decline in the CD4 cell count. After several weeks, as antibody develops, the chronic phase of infection occurs. Here the patient is at their viral load set point, and then their CD4 cell count is at a certain level. This chronic period can go on for years, and there's high variability in the set point of the viral load among different patients. Some patients may have a viral load set point of 100,000, some may have a set point of 500,000 or 1,000,000, and some may have a set point of only 1,000 copies per milliliter. As you can imagine, patients that have a lower viral load set point are going to have a longer chronic phase or clinical latency period because there is less virus attacking their CD4 cells. Patients who have a much higher viral load set point are going to have a shorter chronic phase because there is much more virus attacking and destroying the patient's CD4 cells more quickly. Over time, as the CD4 cell count continues to decline, the patient develops symptoms as well as opportunistic diseases and eventually will die from the virus. This slide shows the risk for selected opportunistic infections at various CD4 cell count levels. Patients with a CD4 count of less than 500 are at risk for developing candidiasis or thrush, as well as Kaposi's sarcoma or KS. Patients with a CD4 count of less than 200 are at risk for pneumocystis jirovecii pneumonia or PCP, which was formerly called pneumocystis carinii pneumonia. They're also at risk for developing histoplasmosis. Patients with a CD4 count of less than 100 are at risk for toxoplasmosis, cryptococcal meningitis, as well as cytomegalovirus or CMV retinitis. And those with a CD4 count of less than 50 are also at risk for Mycobacterium avium complex or MAC. I will end here by providing the list of additional resources that you should refer to and review for this first IPLH session. Thank you for your time and your participation in reviewing this presentation.